on complex Cesarian sections. So you pardon that.
First of all, my thanks and regards to all the seniors. Sunita Madam is here, all the past presidents and the VPs are there. And I am here happy to be here in the Shillong. I have instructions from my president that I have to finish within 10 minutes, not taking too much of time. Just thanking all of you. I just start my presentation. Overcoming the challenges of the complex Cesarian section. So, day to day, we are facing different type of Cesarian section. We have so many complexes. What are the conditions in which there are so many complexes? If we deal with the placenta previa, placenta excreta, spectrum, dense adhesions and the prior uterine surgery, deep impacted fetal head, morbid obesity, rupture uterus and LSCS with the lower uterine segment fibroid. Dear all, if we have all these conditions, we have to be more attentive. So, Cesarian section is among the most common obstetric emergency. Complex Cesarian section, they pose higher maternal and the fetal risk. So, why we should understand the complex Cesarian section? This is because by understanding and anticipating the surgical challenges that enhance the patient's safety. So, what are the things on which we have to put more attention? These are the dense adhesions prior to surgeries. These are the placenta excreta spectrum, obesity, anortical challenges, and advanced maternal age. Intraoperative complications such as hemorrhage or bladder injury, that maybe we have to look into these very conditions. So, how does they complicate Cesarian section? They complicate the abdominal entry by the adhesions. There may be distorted anatomy. There may be risk of heavy hemorrhage. There may be fetal distress and the malpresentation. There is limited surgical exposure, and so in these very cases we have lot many urgency. So this is very important that there should be a proper surgical drills of all the residents, all the surgeons, and they should plan very properly. So, before these cases, we have to review the surgical history and the previous records. The pre-operative imaging should be very proper. These are ultrasound, or in many cases we have to do by MRI for the placental mapping, which is very important in these very cases. You should arrange in these cases blood beforehand. Involve multidisciplinary team. This is very important. You should involve your colleagues of the anesthetists like and urologists and explain them all these conditions which we are expecting. Very important is the informed patient consent and the prior counseling. You should inform your patient that these conditions we may face before, and we have to do, suppose placenta excreta spectrum, you have to do hysterectomy, you have to take consent and counsel the patient and attendance before. So, intraoperative strategies should be planned very properly. Dental layer by layer dissection should be there. It involves a bladder flap creation for the protection. This is very important step which you should be able to do. Stepwise devascularization for the bleeding control is again very important. In many cases, you have to select the classical incision. Use agent like balloon occlusion and the compression suture in case of hemorrhage. So, you should have a proper drill of the managing hemorrhages. Active third stage management should be done by certain medicine which you should have in your OT, oxytocin, calprost and misoprost. You should have tranexamic acid. You should have stepwise devascularization and compression sutures. Training internal iliac ligation, if required, could be done in certain cases. So, what happens if you do and control the bleeding? Should you dance like this? No, you have to do the further planning. Like the post-operative care should be very proper in these very cases, because you have many times you have to monitor these cases in HDU, ICU, early ambulation and thromboprophylaxis is also very important in these very cases. Effective pain management and infection prevention Counseling for emotional recovery is again very important. Documentation for the future pregnancy. That is the time when you counsel your patient for the future pregnancy. There are a few case studies like placenta previa. There was a patient 33 years old, gravida 3 with the previous 2 Cesarian section. Because of the very proper planning, management, pre-operative MRI and multidisciplinary planning was done in this very case, and the blood was arranged pre-operatively, and effective Cesarian hysterectomy was done in this very cases because the patient's attendant, they were all counseled beforehand. And bladder was taken care by the urologist and controlled blood loss and discharged stable on day 7. And you can imagine what happens if we have not planned beforehand and not done any pre-operative planning. This is again the second case of placenta previa in which we have to do the bladder repair. This is a very short video. In this case, we have to placenta previa, do post-operative hysterectomy, and you can see the placenta. There is no space between the placental margins and the uterus. Other very challenging cases are repeat Cesarian section with the dense bladder adhesion cases. 32 years old patient with the previous 2 LSCS presented in the labor with a fetal distress. There were dense adhesions which we found intraoperatively. What were the challenges? They were in this very case difficult to identify the uterovesical fold and accidental bladder serosity that occurred in these very cases. So how did we manage? After taking out the baby, we bladder dissected carefully and repaired by the urologist. Other case which we may face is the obstructed liver with deeply engaged head. In the second stage section, a 25-year-old primary gravida, she presented with a deeply impacted head. So in these very cases, we have to do many times Patwardhan. By Patwardhan technique, we can take out the head, and this is a short video. You can just see by giving the incision. Both the hands taken out. And then the baby pulled. By your reach. Extraction. Then head has been taken out. So rupture of uterus is another very important condition for which we have to be very conscious, because risk of hypoxic ischemic encephalopathy and perinatal death with a uterus rupture stand 6.8%. Cesarian in the severe preeclampsia with HELLP syndrome. There was a patient, 28 years, BP so high and platelet low, elevated LFT. Intraoperatively, we have to take care of the oozing incision site and the friable tissue. So, meticulous suturing should be done and blood product should be ready. Why complex? Because there may be coagulopathy or hemodynamic instability. Other challenging cases, Cesarian with a large segment uterine fibroid. In this case, what are the challenges? These are the fibroid obstructing incision site, and there was a limited space. So what we do is a vertical incision above the fibroid, and myomectomy deferred. There is a lot much of discussion. We should defer the myomectomy in these very cases. Other morbidly obese patient with a gestational diabetes. In this case, what are the difficulties? Spinal anesthesia, poor exposure and thick abdominal wall. And post-operatively, management of the wound infection. So, there should be experienced team, modified incision has to be taken, post-operative care of DVT prophylaxis, and so these are few points in the pathological obesity which we have to take care. Because of the short time, I am not taking in detail. Many times, in these cases, you prefer penicillin incision. Moisture, post-operatively moisture is a problem in these very cases. And if the thickness is more than 2 centimeter, you have to give subcutaneous infection, subcutaneous stitches, while subcutaneous drainage is not recommended. Raise the head of the bed by 15 to 20 degree to relieve the shortness of the breath. And if adipose penicillus is not mobile, many cases, in case patient is not planning for the repeat cesarean section, you have to give supraumbilical incision. So in summary, complex cesarean section demand planning and the precision, teamwork and the preparedness are key to reducing the complications. Advanced technique and the training, they improve the maternal safety. It is mandatory that the obstetrician should receive initial and ongoing focus on recognizing condition of the increased risk and have adequate experience in managing multiple complications frequently associated with the cesarean section. Thank you very much. I think I have finished in time.
Thank you, ma'am, for your nice lecture. Here we end the session. We are actually running by almost 40 minutes late here. So, as it is a high risk pregnancy session, can we take any question? Organizer. I think we can take 1 or 2 questions here.
Madam, one thing, I have experienced one patient with a huge myoma, anterior wall myoma of 12 centimeters, with 37. I had a planned pregnancy, 38th week, I terminated. But since it was pre-planned, I knew I had to face this. So what I did was, within 3 minutes, I removed the myoma, and then I proceeded with the breech delivery of the baby. But everything was okay. So at times we have to face some challenges, we have to take steps. But my consent of operation was very strictly taken. Yes. I told them that can be messed up, but I have to try.
That is decision by the surgeon intraoperatively. Many times you can do or you can defer depending on the condition you face.
One question for Dr. Sangeeta ma'am. Ma'am, regarding the second trimester, you said you were going to go for operation in case of serious cervix. Can you tell us what type of operations would you prefer?